a talk that I gave in China last year. So really what I'd love to discuss today is just to briefly review the physiological rationale for why we might want to give a colloid versus a crystalloid fluid to resuscitate our critically ill patients with sepsis. And then we'll go into discussing the clinical evidence for using our colloid fluids in Canada. The two dominant colloid fluids that we have available for use being hydroxyethyl starch fluids and albumin in the setting of sepsis. And then I'll finish off with a short discussion about the quantity of fluid and how we give that fluid and how that controversy is beginning to emerge more now. So first, just starting with the rationale for why we give fluids, resuscitation fluids to our critically ill patients. When we resuscitate with a colloid as compared to a crystalloid fluid, at least from the theoretical standpoint or from a healthy volunteer perspective standpoint, that colloid fluid is supposed to remain in the intravascular space. All of it's supposed to stay there. And so in comparison to a crystalloid fluid, where when you give crystalloid, 2/3 to 3/4 of that fluid immediately leaks out of the intravascular space into the interstitial space and then eventually into the intracellular space, all the colloid's supposed to stay intravascularly. To get a bigger bang for our buck when we resuscitate colloid. In fact, when you look at the textbooks, the ratio often is cited as for every one colloid that you give, you're going to give 3 to 4 crystalloids. But the question is whether or not that actually holds true in our critically ill patients. Are colloids truly better maintained in the intravascular space compared to crystalloid fluids? And I can tell you that a number of randomized controlled trials have been conducted in the critically ill and or septic shock patient populations, comparing the colloid, either albumin or starch, to a crystalloid fluid. And the consistency of the effect here is really remarkable in that when you look at the right-hand column, the ratio of colloid to crystalloid that is given in those randomized controlled trials is more like either 1 to 1.1 all the way up to 1 to 1.4, but never do you see a ratio of 1 to 3 or 1 to 4. So do you save in our critically ill patients? Yeah, you save, but you probably don't save near as much as you might think, or if you're giving it to a healthy volunteer. So why might that be? We think here is that because our critically ill patients who are in need of acute volume resuscitation because of hemodynamic instability, have profound endothelial cell dysfunction and endothelial cell leak. So a lot of that colloid that you're giving is actually rendering ineffective, and it's leaking into the interstitial fluid space. Wow. A lot of studies have been conducted looking at the issue of colloids versus crystalloids, or colloids versus colloids, or albumin versus no albumin, or starch versus other fluids. And none of these systematic reviews have been able to definitively determine whether a type of colloid is better than a type of crystalloid fluid. And loads of studies have been conducted, so you may ask the question, why are we continuing to ask this study question since we have so many trials? Well, the reason is, up until recently, very few critical care trials have been conducted. So in our population where patients are profoundly ill with profound endothelial cell leak. In addition, the older trials had outdated protocols. They compared heterogeneous fluids. They had different fluid comparators, used different doses, used different timing of the study period with the fluids, and many of them suffered from a high risk of methodological bias, rendering us to question the believability of studies. In addition to that, we have recent data emerging that the type of fluid, or the same type of fluid that you give, may have disparate effects in different patient populations of our critically ill. So for example, TBI with albumin, maybe not so good, and we'll talk about that in just a minute, because I know the focus is on sepsis here. But just to illustrate the point, the alternate is that albumin in the setting of sepsis may be helpful in this setting. So let's talk a bit more about that as we go along. In addition to why this is kind of a big deal, this whole fluid resuscitation paradigm, is that I think we have strong beliefs with regards to the fluids that we use. And they really, other than administering oxygen to our patients, it's really the most common intervention that we employ for these patients. And recent research in fluid resuscitation has really put this issue in the spotlight, not even just the what type, but the how much. And we'll talk about a little bit more about that in a minute. In addition, or just to highlight, that there appears to be a ton of variability with regard to the type of fluids that we use across the world. So Finfer and colleagues published this in Critical Care in 2010, and this was an international cross-sectional study looking at fluid resuscitation episodes in 391 ICUs in 25 countries around the world. And using Canada as our base, crystalloids in blue bar, colloids in yellow bar, using Canada would appear to use similar amounts of colloid and crystalloid fluid for the resuscitation episodes. Whereas when you look at Great Britain, the UK, the dominant fluid used there is actually colloid. And really, the dominant colloid in Great Britain was the hydroxyethyl starch fluids. And so there's a lot of variability in fluid resuscitation practices, and we think at least that is in part explained by, at least up until recently, lack of strong definitive evidence to really guide our practices. In addition to that, this whole type of fluid question has been subject to heightened controversy and new recent evidence. Unfortunately, we have, with regard to the heightened controversy in the last 2 years, discovered that a very resuscitation researcher in Germany was found to have fraudulent data in one of his trials and underwent some scrutiny, and through an investigation, several of his trials are now either fraudulent or were not noted to have undergone research ethics approval prior to being conducted. And so most of these trials were with hydroxyethyl starch, so that really served to heighten our controversy. And of course, we have a very recent publication in the New England Journal of Medicine that I'll highlight, suggesting that starches in sepsis specifically are probably very harmful. But what do Canadian docs, ICU docs, say that they use for resuscitation in early septic shock? We conducted this survey a few years ago now, back in 2005 and 2006. It was several years ago now, I'm dating myself. And at that time, when we asked docs about what their favorite fluids were, when we asked about the crystalloid fluid, both normal saline and Ringer's lactate were used often or always the most, 88% and 56% specifically. Asked about the colloid use, the dominant colloid for early septic shock resuscitation at that time was the colloid pentastarch, with very little albumin being used in that context. So let's talk a little bit about what those hydroxyethyl starch fluids are, since they are used so much to resuscitate our patients. Well, these starches are really just amylopectin starch, and they're branched-chain glucose molecules that are synthesized by corn or potato. But if we didn't hydrolyze them, they'd be rapidly mopped up by amylase, so their half-life is very, very short. So in order to increase their half-life, the manufacturers hydroxyethylate them at the second carbon and the sixth carbon, and that's what we call the amount of substitution for the hydroxyethyl starch. And that becomes important because amount of substitution, to a great extent, determines how long those starches stay in the intravascular space. So there's a few different starches available for use in Canada. One of them is the pentaspan or the pentastarch, and the more current version is Voluben or Volulite. And they differ with regard to their molecular weight. Pentastarch is about 200 or 250 daltons versus our Voluben, which is 140 kilodaltons. And they differ with regard to their concentration as well, up to 6% versus 10%. And in regards to how much they're substituted. So at the C2 and the C6 carbon, so for example, with the pentastarches, they're about 45 to 50% substituted, and with the Voluben product that we have in Canada, it's more around 40% substituted. The ratio of substitution is also somewhat different between these two fluids, and the carrier fluid, meaning the carrier crystalloid fluid that's in those starches, can differ between like a Ringer's-like solution versus a normal saline. So what is the current evidence? Because you say, well, these are all biochemical differences, but what about the clinical differences between these starches, and are they clinically significant? So what's the current clinical evidence for use of hydroxyethyl starch fluids for patients with severe sepsis and septic shock? Before I talk about the Perner, this is the success study that I'm going to mention to you. I should mention that previous trials in sepsis using different types of hydroxyethyl starch fluids have been used, and there was a suggestion in the past that perhaps in the setting of sepsis or severe sepsis and septic shock that these fluids may be associated with the development of acute kidney injury and possibly death. But none of these data were deemed to be confirmatory, and they also did not employ the use of our newest hydroxyethyl starch, more of the volumen, the smaller one. And so Anders Perner and colleagues in Scandinavia conducted this trial and published it in the New England Journal of Medicine last year. So it was a multi-center randomized double-blind trial in 798 patients in the ICU who had the diagnosis of severe sepsis and who met that eligibility criteria within the previous 24 hours. They were randomized to a tetraspan, so it's a 6% hydroxyethyl starch, 130 kilodaltons, with a substitution of about 42% versus Ringer's acetate, and the maximum daily dose allowed was 33 mils per kilo. The primary outcome was mortality or dependence on dialysis at 90 days in that trial. With regard to the baseline characteristics in that study, the age was similar between the two groups, as was the sex. About 60% of them were male. The SAPS-2 scores were also similar to indicate how severely ill they were. The vast majority of them were in shock at baseline. About a third of them had acute kidney injury at baseline, and almost two-thirds of them were ventilated at baseline. So very similar baseline characteristics between the two study groups. With regard to fluids administered, they received similar amounts of fluid in the 24 hours before they were randomized. And with regard to the randomized fluid, they received a median of 3 liters each. So one of the criticisms from the previous Starch trial, called the BICEP trial, was that patients in that study received so much starch, up to 250 mils per kilo. And one of the criticisms was, well, the reason that there was harm noted in that study related to the fact that they just gave loads and loads and loads of starch. Well, this study didn't seem to give lots and lots and lots of starch. So just to make that point, very little open-label synthetic colloid use between the two groups, and less than 10% less than or equal to 10% in both groups received doses that superseded the maximum protocol. With regard to their primary outcome of death at 90 days or dialysis dependence at 90 days, there was an 8% absolute increase in the risk of that primary outcome in the starch group as compared to the Ringer's acetate group. And all of that outcome was made up at 90 days of death. So there was an 8% absolute increase in the risk of death if you were resuscitated with starch as compared to the crystalloid fluid. With regard to the requirement for renal replacement therapy during the study period, there was also a significant increase in the requirement for renal replacement therapy for the starch versus the Ringer's acetate group of about a 6% difference. What about the methodological quality of this trial? If you remember in the past we talked about the fact that a lot of these older trials were at a high risk of bias. Well, this trial was considered a high quality trial and therefore at a low risk of bias. The allocation lists were concealed, randomization was done well, the trial was double-blinded, there was few losses to follow up, there was an a priori sample size calculation, and the results are generalizable. Several centers in Scandinavia participated in this study. There were also few protocol violations. Similar amounts of fluid were used in both study groups. The doses of HES, or hydroxyethyl starch, were not excessive, and they received similar amounts of fluid pre-randomization. So all of these points make the data that is generated from this randomized controlled trial to be very robust. In addition, Myberg and colleagues, our Australian colleagues, conducted another very large randomized controlled trial of starch versus saline, and this one was also published a little bit later last year in the New England Journal of Medicine. And this trial was a double-blind, multi-center randomized study where they randomized 7,000 adult patients who required a fluid bolus in the intensive care unit. So not patients with severe sepsis or septic shock, but patients who were hypovolemic in the ICU. And they were randomized to a 6% HES, and this is again like a Voluben-like product, versus normal saline for the duration of their ICU stay. The age was similar between the two groups, as was the proportion of male, again about 60%. The Apache 2 scores were also very similar, but note that the Apache 2 scores in this study were about 17. So a little bit lower than what we might expect for patients that have severe sepsis or septic shock, which is upward of 20 and above. Also, quite a few surgical, post-operative surgical patients in this study, about 43%. And in terms of the time from to enrollment in the intensive care unit, the mean time was about 11 hours from when they came into the ICU to when they got enrolled, and it had to be their first fluid challenge in the ICU to be able to get enrolled into the study, otherwise they were excluded. So that's also an interesting point. At the time of study entry, nearly 50% of them were on vasopressors, about a third of them as well having acute kidney injury, and about 2/3 requiring mechanical ventilation. With regard to the amount of study fluid, similar amounts of study fluid given between the two groups. The point that I would make here is just the amount of fluid that was given. So it was about the equivalent of a bolus of crystalloid or colloid, about 526 in the HES group versus 616 in the saline group, compared to the 3 liters that was given for the patients with severe sepsis and septic shock in the 6S trial. A little bit more blood in the starch as compared to the saline group, but not a lot of blood, less than 100 mils between the two groups. And the CVP over that first 4 days was statistically higher in the starch compared to the saline group, but I think we'd probably argue that that would not be considered clinically significant, 11.3 versus 10.4. With regards to the outcome, the primary outcome of 90-day death, it was 18% versus 17% in the starch versus saline group, with a non-significant finding. So very similar, actually, between the two groups in this trial. With regard to a secondary outcome of acute kidney injury and requirement for renal replacement therapy, the use of renal replacement therapy was noted to be higher in the starch as compared to the saline group, the absolute difference of 7 versus 5.8%. And a number of subgroup analyses were conducted in that study. Now, we have to be careful about interpreting subgroup analyses because the more subgroups that we examine, the greater chance that we'll have of finding a statistically significant result by chance. But that being said, subgroups can be certainly used to generate hypotheses for future research endeavors. And just to highlight a few, with regard to the diagnosis of sepsis at randomization in the CHEST trial, the absolute death risk was 25%, 25.4 versus 23.7%, not statistically significant, represents a subgroup, and as John Myberg says, the risk of death with the confidence intervals are within the realm of the risk of death that was seen within the 6S trial, but certainly not statistically significant here. With regard to trauma, not a lot of patients, under 500 patients, or about 500 patients studied in this subgroup, and actually very few deaths, and no signal there, and really not enough patients with traumatic brain injury studied within the CHEST trial to really to really comment on, just over 57 patients. So the chest conclusions really are that there's no benefit of starch over saline for the treatment of hypovolemia in the critically ill. There's a small potential harm risk with HES with regard to the requirement for renal replacement therapy. And because HES is so much more expensive compared to crystalloid, there's really not a good rationale or justification for using it for resuscitation in our critically ill patients. Questions, though. Should we generalize the chest findings for patients who present with septic shock, trauma shock, or for the postoperative patient population? So the septic shock patient population, I bring that up because you might say, well, why is it that chest found really in that subgroup analysis there didn't seem to be a very significant signal of harm for HES in chest? And one of the thoughts here is that the patients, if you remember, the time to randomization was on average about 11 hours from ICU admission, and the mean amount of fluid given was about equivalent to 1 bolus. And so it makes us wonder how sick the sepsis patients were in the chest trial as compared to in the success trial. And I'm quite sure the chest investigators will be publishing a further subgroup analysis and giving us a lot more detail on that subgroup, hopefully in the near future. I'd say the same thing about the trauma shock patients and the post-operative patient population. I believe there's more data to come to us. If you're interested in reading, a few investigators, our group being one of them, have, since the publication of these 2 trials and a few other smaller studies, updated the clinical evidence for starch in our critically ill and with sepsis in the setting of systematic reviews and meta-analyses. And the general gist of the conclusions from these trials and meta-analyses is that there appears to be harm with regard to resuscitation of starch for the critically ill and those with severe sepsis and septic shock. So I've provided those there for you for future reading references if you'd like to have a read of them. So in summary then, with regard to the Starch story for severe sepsis and septic shock in 2013, best to avoid using it as a resuscitation fluid due to its increased risk of death and development of acute kidney injury, and this is supported as a grade 1B rating from the surviving sepsis guidelines that were just recently updated. For now, I'd avoid using it as a general resuscitation fluid in the critically ill due to the chest data. And the final conclusion is that the newest tetrastarch really was used in these most recent trials, and it doesn't appear to be any more safe for use in our critically ill patients with severe sepsis and septic shock, or the critically ill for that matter. Well, what about albumin? Okay, so albumin's another colloid that we have approved for use in our critically ill here in Canada, or as a resuscitation fluid. And we know that albumin's derived from a pooled plasma. Its molecular weight's about 66 kilodaltons. It's made in the liver. It's negatively charged. It's the most common plasma protein that we have available in our intravascular space, and its concentration in our plasma is about 40 grams per liter. It's available in an iso-oncotic form, 4 or 5%, or the hyper-oncotic form, 20 to 25%. And so the difference clinically here is that when you resuscitate with the iso-oncotic form, you're supposed to maintain that fluid in the intravascular space, whereas when you resuscitate with a hyperoncotic fluid, at least in theory, you're drawing fluid from that extravascular space into the intravascular space. And again, I say that theoretically or in healthy volunteers because in our critically, it's really not clear that you recruit a whole lot of extra fluid. Okay, what are the functions of albumin? Well, they have several functions. Its main function is it's the biggest maintainer of colloid-oncotic pressure. It's a transport protein, and it binds to many different electrolytes and to metabolites and to drugs. In addition to that, it binds inflammatory mediators, and some studies suggest that it actually has antioxidant effects. So as a resuscitation fluid for our critically ill and patients with severe sepsis and septic shock, there appears to be some biological plausibility for why we may consider using this fluid in this setting. But what's the evidence for albumin then in our critically ill? Really, the bulk of the present evidence comes from the SAFE trial that was published in the New England Journal of Medicine from our Australian colleagues in 2004. And if you remember, this is a 7,000-patient randomized, double-blind, multi-center trial where patients were randomized to blinded 4% albumin versus normal saline for the duration of their ICU stay, with 28-day mortality being their primary outcome measure. And what they found in the SAFE trial was overall, for hypovolemic patients, heterogeneous critically ill patients, absolutely no effect, no benefit for albumin over crystalloid fluid. When you look at subgroups, though, two different subgroups, let's take the trauma subgroup and the severe sepsis subgroup, there appear to be potentially disparate effects. Same fluid, different subpopulation of patients. So let's explore that in a little bit more detail. So first, that subgroup analysis of patients with traumatic brain injury from SAFE. So that included a total of 460 patients. And to get into this subgroup, you needed to have a GCS of 3 to 12 and an abnormal CT scan finding with regard to the traumatic brain injury. Baseline characteristics between the two groups look pretty similar. And in this subgroup analysis, there was a remarkable signal at 28 days and at 24 months where survival in the albumin group as compared to the saline group was actually reduced. So colloid in this setting of traumatic brain injury may be associated with harm, and specifically, in this case, albumin. What is causing that? Well, they've done some looks at this data, and it looks like part of this might be related to rises in intracranial pressure. So in somebody that has disruption of their blood-brain barrier, infusing a colloid fluid into the brain and into a tight space in the brain may serve to draw fluid with it and raise the ICP. So it's possible that may have been a mechanism that led to death for these patients. So probably avoiding it in this population is a good idea. And just to highlight, in the patients that had very severe TBI at baseline, those with GCSs of less than 8, the risk of death was even higher. Okay. But let's get back to sepsis, because that's what we're talking about today. They also did a predefined subgroup analysis of patients with severe sepsis from the SAFE trial, and this included 1,218 patients. And in this subgroup, the baseline characteristics between the two groups look pretty darn similar. The mean arterial pressure was a little bit higher in the saline compared to the albumin group at baseline, but difference between the two groups is probably not clinically significant, 74.5 versus 72.6 for mean arterial pressures. The other thing was that in this study they were unable to document filling pressures between the two groups because there were so many missing central venous pressures at baseline, almost 60% of them. So we don't know for sure if these patients were similarly filled at baseline. With regard to the amount of study fluid received in that first 3 days, in the albumin group, they did receive a little bit less fluid compared to the saline group. The absolute savings was about 400 mils on day 1, and all the way out to day 3, it just continued to decrease, as did the amount of fluid given, which we'd expect because the resuscitation for that severe sepsis and septic shock occurs really over that first sort of 24-hour period. With regard to physiologic endpoints, the mean arterial blood pressure was similar, the heart rate was similar, the albumin levels were higher in the albumin group compared to the saline group as expected, and on day 2, the CVP was higher, statistically higher in the albumin compared to the saline group, and the difference was less than 2 between them. So many of us question again the actual clinical significance of that difference in the CVP. With regard to the outcome for this subgroup analysis, in an adjusted analysis, a logistic regression analysis with 28-day mortality as a primary outcome, resuscitation with albumin as compared to normal saline was associated with a 29% reduction in the odds of death for patients with severe sepsis. So if true, that would that would represent a very large reduction in death for our highly vulnerable patient population. But as we say, again, this is a subgroup analysis from a very large randomized controlled trial. It required adjustments for the baseline characteristics. The trial really wasn't intended to be conducted specifically in this patient population, so many of us still question whether or not albumin, if given in the setting of severe sepsis and septic shock, is actually beneficial. The good thing also, though, in this subgroup analysis is that there were no detectable differences in renal injury between the two fluid groups. So at the very best, it does not appear to be harmful, the very worst, it doesn't appear to be harmful, and the very best, it actually may be helpful for resuscitation of our patients. That's also about 50 times more expensive, bolus for bolus, with regard to crystalloid. So there is additional albumin and sepsis data or evidence coming. Two large trials, one is the EARS trial and the other is an Albius trial, conducted in France and in Italy, respectively, have been completed. And these first two trials, the EARS and Albius, looked at patients with severe sepsis or septic shock, and they actually gave these patients hyperoncodic albumin infusions rather than boluses of isooncotic fluid, and as compared to crystalloid fluid, with primary outcomes of 28-day mortality or 28 and 90-day mortality. And hopefully that data will be published soon, so there should be more evidence coming to help us determine the role for albumin in sepsis. In addition, there's another trial in Brazil called the RAST study that is randomizing patients with severe sepsis or septic shock early within 6 hours of evolution, and they're resuscitating them with more of an isooncotic albumin, 4% versus Ringer's lactate, until the CVP is 8, or until they've recovered from hypotension, and with a primary outcome of 28-day mortality. And hopefully that will also generate us more data. Finally, just to highlight one more trial, this is a Canadian-based study called the PRECISE trial that hopefully plans to randomize a whole bunch of Canadian critically ill patients from the emergency room and the ICU to blinded 5% albumin versus a crystalloid fluid for patients with early septic shock with a primary outcome of 90-day mortality. We have conducted a pilot trial called the PRECISE pilot, and the main reason we conducted that pilot trial was to establish whether or not it's feasible to go on to conduct a trial of 2,000-odd patients in an international setting. From our pilot study, we were able to ascertain that, in fact, this trial is feasible, and I can tell you that our team, our international team, is coming back together, and our plan is to submit this trial to CIHR for this coming March, and we hope we'll get this funded and hope to be able to answer this early septic shock fluid resuscitation trial question of albumin versus crystalloid fluid in the next year, so that we have more data to help inform us with regard to albumin for resuscitation in this setting. So, but to summarize the evidence then that we have right now, with regard to the surviving sepsis guidelines, it's actually now a weak recommendation to consider using it for resuscitation of patients with severe sepsis or septic shock. Probably not to consider using it for patients that are just hypovolemic, and not necessarily because there's harm, but because there doesn't really appear to be any benefit for giving albumin versus crystalloid in that setting. And we probably would suggest avoid using it for now in the setting of traumatic brain injury until more data is generated to say otherwise that in fact it's not harmful. But for right now, that subgroup analysis data is pretty compelling to avoid using it in that particular setting. So just to finish off with this whole quantity of fluid question, because I think certainly when I trained way back when, the thinking of giving fluids back then, resuscitation fluids, was just bang in that fluid and get it in until they're bubbling over, until you actually have to intubate them, or you can intubate them if they start to get worse from a respiratory point of view. But I think we're getting more and more concerned about that sort of frame of thinking, and there's some data to support that we probably should be a little bit more concerned about how we give our fluids as well. We have some data from an ARDS trial that was a 2x2 factorial design study. One was to examine the study question of using a SWAN versus a CVP to guide fluids, and the other was, the other factorial part of the design was to examine a conservative versus a liberal fluid strategy for patients that had acute lung injury and ARDS within 48 hours of ICU admission, suggesting that if you restrict your fluids in that context, the patients had less ventilator days. So that's one line of evidence that suggests that maybe we shouldn't be so aggressive with our fluids. But remember that that's not up front in the emergency room or very early in the resuscitation. This is more within 48 hours of ICU admission. In addition to that, there's another observational study that was conducted, though, in the setting of septic shock, and this is a nested study from a Canadian vasopressor trial where they were able to ascertain an association between a positive fluid balance and an elevated central venous pressure and an increased risk of death. So suggesting that excess fluid in that setting is associated with an increased risk of death in this observational study where they adjusted for multiple confounding influences. It is an observational study, so we have to be a little bit cautious with regard to how we interpret these data. And so what randomized controlled trial data do we have? Well, right now, there's one published study looking at this quantity of fluid question, and it really comes from Africa. And Kath Maitland published this study in the New England Journal of Medicine in 2011. And she randomized just over 3,000 African children who had febrile illness and impaired perfusion. And most of these patients with the febrile illnesses had malaria. So about 60% of the patients enrolled in the study had malaria. And they were randomized to boluses of 5% albumin versus saline, or no bolus, just a maintenance fluid. And the 48-hour risk of death, as well as the 4-week risk of death, was lower in the kiddies that were given the control regimen, not the aggressive fluid bolus regimen. And I can tell you that this study has generated a lot of discussion, controversy, emotion with regard to how we interpret these data, because many folks say, well, come on, this was done, number one, in kids in Africa, in a low-resource country where intubation is not possible, giving vasopressor is not possible, putting EVDs in for high ICP is not possible. So how can you generalize these data to North America and Europe, for example? But I think although it was conducted in this setting in a very different patient population in a low-resource area, I kind of think that it should cause us at least pause and cause us to question potentially some of the very basic elements of how we give our fluid. And I'm not at all suggesting right now that we shouldn't be giving bolus resuscitation for patients that have septic shock, but I think that this study just highlights how much more potentially we have to learn about not just the type, but how much and how we actually give our fluids for patients that have severe hemodynamic instability like septic shock. That's all I just wanted to say. That's my end. Thank you so much for your attention.
Wow. Thank you so much, Lynn. That was just a fantastic lecture and a great review of all of the evidence. I'd like to open up to all the attendees for questions, and you're able to put up your hand using that side panel. If you're interested in asking a question, maybe I'll start the group off, and maybe, Lynn, I'll put you a little bit on the spot and ask you about what you think we should be doing with albumin in early resuscitation of septic shock. As a lot of the people on this call are emergency physicians or work in the emergency room, and so if we have someone who comes in and they're in profound septic shock and we're resuscitating with crystalloids, should we be giving albumin in the emergency room? What ratio of albumin to crystalloids should we be using, or what's your best guess and what do you do?
You know, David, to honestly be honest, I don't know. Like, I like with regard to the evidence, I think that the existing evidence that we have for using albumin in septic shock is from that right now from that one SAFE subgroup analysis. The data from Albius and from the EARS trial are hyperoncotic albumin infusions, and they're not really given in the context of patients that are super hypovolemic in the emerge or early in the intensive care unit requiring, big boluses of fluid. It's more like to try and recruit fluid from the extravascular space, that sort of context. So to be honest, I'm not even sure how much more data the EARS and Albius trials will give us with regard to helping us ascertain whether we should use albumin versus crystalloid. But what I do right now is I start with crystalloid fluid. I usually bolus them up with a couple liters of crystalloid fluid, and then just depending on how the patient's doing, I might use albumin. I certainly don't use starch anymore, but I may use albumin. But I usually use both of them, and I wish I could say I have a preference, but at the moment I just don't, because I don't know. God, but I'd love to have an answer to the question. I don't know if others have thoughts or if we could open this for a discussion.
And maybe I'll just on that same note, when you are using it early on, do you trend, if you are going to supplement a little bit, do you find yourself using the 5% or a more higher oncotic, such as 25, in the early phases, or does it just depend?
5%, Dave, and again, I'm not even sure if that's completely correct, but that's what I do. And the rationale I would use it early, if I'm going to use it early, and the more hypovolemic patient, is that if we think that our interstitial space and or intercellular space is somewhat depleted in the hypovolemic patient, then by giving a hyperoncotic fluid in that setting, you're just drawing even more fluid and depleting that space even more. So for the hypovolemic patient in shock, if I'm going to use albumin, it would be more the 5% albumin. Where I tend to use the more hyperoncotic albumin is after I've finished resuscitating the patient and they're more hemodynamically stable and I'm trying to actually offload fluid, then I may give it as an infusion in conjunction actually with Lasix to try and get the fluid off of them. But that's certainly not an emergency room or early ICU sort of resuscitation measure.
Interesting. Yeah. It's very similar to some of the practices I have. And sort of I've always made correlates with the burn literature and some of the suggestion now with the burn patient that when we're hitting very high volumes of crystalloid, that supplemental albumin may be a benefit. Right.
Yeah.
I'm just looking through the list. Is there anyone that has any questions for Dr. McIntyre? You can put up your hand. No, I'm not seeing anyone else. Maybe I'll ask one other final question, Lorlyn, that crosses my mind occasionally. And looking at sort of resuscitation in early septic shock, is where do you think is the appropriate point in a patient who's fluid responsive? Should we be adding vasopressors? And what I mean by that is there's the patient that does seem to be responding to fluid, and we're going 2, 4, 6, 8, 10 liters of crystalloid, and they seem to respond when the blood pressure comes up, and then it seems to be drifting again.
Yeah, absolutely, because we know that no matter what you give, it is going to leak, right? Like a lot of that fluid is going to leak. So I guess the initial rationale is, okay, they're super hypovolemic, let's fill up their space as much as they can, and who knows, maybe, at least there's some data, although it's weak data, suggests that maybe when we resuscitate early and aggressively, we can also enhance recruit the microvasculature, enhance microvascular perfusion, reduce cytokinemia, reduce ischemia, reduce all that other stuff, right? So all that's sort of in the early part. But I really agree with you that once you get them resuscitated, and you're so right, I think, so maybe you're not right at the very top of the flat part of the Starling curve, but maybe you're getting close to it. The lactate's coming down. They're starting to make urine. The creatinine's coming down. They're warm perfused. They've got brisk cap refill. Their vasopressors are not continuing to increase. So you know what? I tend to stop then. I think our fluid resuscitation practices are really evolving. Like, seriously, when I first trained, whatever, 15 years ago, it was like, just fill them up until they're bubbling. I know that sounds so not technical, but it really was, just get them as high as you can, get them to the flat part of the curve. But I think we're getting a lot more finessed with how we give our fluids now, that's for sure. And I think, more research is required for sure.
Yeah, I agree. And again, correlates with the burn literature. We know that over-resuscitation is bad. And even though you may be volume responsive, such as you and I may be volume responsive sitting here right now, if the main primary problem is vasodilation, maybe they don't need all that volume. And in fact, they need some and moderate amounts of volume with vasopressor therapy until your antibiotics kick in and the rest of it, the vasodilatory component of their shock is reversing. And so maybe a fluid isn't always the best answer. But obviously, that has to be carefully done to make sure not to under-resuscitate.
I think the other kicker there, Dave, is that it's attention to detail, isn't it? So you can say, oh, yeah, well, I think they're okay. Their cap refill's pretty good now. I've given 5 liters. Maybe I should stop. That's enough fluid. But if their lactate's continuing to go up, if their SVO2 is, 55%, if their cardiac output or whatever filling pressure measurement you use is saying their CVP or whatever it is low, then you'd still give them fluid, right? Like you wouldn't use it as a recipe to just say, oh, I've already given 5 liters, I better stop. I think it's attention to detail and multiple measurements, multiple different ways of looking at the patient to ascertain whether or not you think they're adequately resuscitated. And the other key feature is that that's a point-in-time assessment. The key is to continue to reassess. At hour 0, this is what they were like, and it's now 2 hours later, and the levofed's gone from 10 to 20, and now their perfusion is terrible, and their lactate's gone from 2 to 6, that kind of thing. So,
without question, the dynamic moving target and continuous reassessment is important. And even some of our previous lectures have been on methods of determining volume responsiveness and techniques such as ultrasound, pulse pressure variation, for example, and combining those with your clinical and your physical exam to determine where they are on that Frank Starling curve and how volume responsive and how much bang for your buck you're going to get, really.
Yeah, absolutely. Yeah, absolutely.
Wonderful. Okay, well, I'm going to open up one last time if there's any other questions that pop up there. Maybe why don't we just unmute everyone for 1 second just in case people are having questions with having issues with putting up their hand. Does anyone there have any questions?
Everyone's unmuted. If anybody has any questions, you can either shout or...
Nope, I don't think so. Why don't we mute for a sec? Well, I just want to thank you again for giving this presentation. It really was one of the better presentations I've seen on fluid resuscitation and septic shock. If, just as another note, if you're interested in joining the BC Sepsis Network, anyone, you can see on the screen right now how to join the network and to get to our homepage. And we'll make sure to keep updating you on future lectures and future activities of BC Sepsis Network. Thank you so much, Dr. McIntyre.
It's a pleasure. Have a great day.
Thanks for attending.
Okay. Thank you, everybody.
Bye-bye.
Bye.
Bye.